What's up, Des Moines? Doc Loud here with the Fit Moines podcast, where we sit down with the people helping Iowans feel better, move better, and perform better. Today, I'm joined by Dr. John Jager, a foot and ankle surgeon at Arch Foot and Ankle, specializing in sports medicine, reconstructive surgery, and comprehensive foot and ankle care. If you've ever dealt with heel pain, recurring ankle sprains, wondered whether custom orthotics are worth it, or simply want to keep your feet healthy so you can stay active for years to come, this episode's for you. Dr. Jager, welcome.
Thank you for having me.
Yeah,
Good to be
absolutely.
here.
I'm super excited for this. So let's hop right into it. First question, why podiatry? Was there a moment when you knew this is what you wanted to do?
Yeah, so I think that moment came probably a little bit later in my schooling and whatnot. So I started school pre-med, knew I wanted to get in medicine in some way, and kind of after undergrad, I was still kind of undecided. So I worked as a scribe and worked
Okay.
over here in Des Moines, and worked with a bunch of different specialties. One that stuck out with me was podiatry. So I was fortunate to work with some pretty good mentors in the field, and they kind of took me under the wing, kind of showed me, the different aspects of podiatry and foot and ankle related. Always been interested in the foot and ankle just because it's something that I think we take for granted. We're always on our feet. It's how we get around.
Yeah.
And, it's just something that keeps us moving. And I've always been interested in sports injuries as well. Been, involved in athletics all my life. So that had a big role in it. But kind of back to, working as a scribe and seeing all the different types of procedures. Every patient's a little bit different. Whether it's, just like an ankle sprain, or if it's a fracture, or, anything along those lines, just general foot pain. There's always different types of procedures that we do in the office. And then that leads into the surgery, or excuse me, into the operating room as well. There's just a lot of different pathologies that we can treat from, both a conservative and a surgical standpoint, with different ways to do each one.
Sure. What's the hardest thing about becoming a foot and ankle surgeon that people never see?
Well, there's kind of multiple different ways for that. Some people don't like feet. That's always a big thing that people have to get over. But, that stuff, that's with any specialty in medicine. You're going to see
Sure.
stuff that, you don't always want to see.
Yeah.
I think some of the more difficult things is seeing a patient that you can't help a lot. Right? There's some pathologies, there's some deformities that no matter what you do from a conservative or a surgical standpoint, you may not be able to get them back to, moving like they were before their injury. That's mostly, severe flat foot deformity. We want to get them to a point where they can walk and, do the things they want to do in life, but we can't always get them back to what they were beforehand. And I think that's one of the toughest things that I see with being a foot and ankle surgeon.
Can you kind of describe just the process of becoming a podiatrist and
Yeah.
what that looks like?
Yeah. So undergrad, do all that, then you take the MCAT, and then you apply for podiatry school. So podiatry school is a little bit different than MD or DO school. And the fact is specialty kind of driven right from the get-go. So I went to Des Moines University. Our first 2 years, we take a good majority of the classes with the DO class. And then kind of towards the end of our second year, we start to get real specific into the foot and ankle. And then we do that for a total of 4 years. And then it's a 3-year residency afterwards. I did my residency down in Orlando, Florida. And then there's the option to do a fellowship, usually for a year or two after residency.
Okay. Looking back at residency, what humbled you the most?
We worked a lot. So there's a lot of things. I think, we were fortunate in a way to be in one of the biggest emergency departments in the Southeast. So the humbling thing is that everything that came through, there could be some conditions, bad diabetic foot infections where that, this patient probably isn't going to do well from either, they're either going to lose their foot, leg, or they're at the risk of
Yeah.
losing their life. That stuff really humbles you. And then just seeing, patients, who are just kind of down on their luck. They want to get better, but they've had a tough pass, and they're not able to get to the spot that they want to. And, trying to get them to get to the level that they want to be. Just kind of working through that with them. I think those are the most humbling things that I've kind of experienced during residency.
Sure. Yeah. And I know those long days, a lot of hours put in. I'm sure that's not fun, but that's how you get good, right? Just a
Exactly.
lot of it's just reps and seeing things over and
100%.
over and over again. And you start it's pattern recognition, right? That's a lot of what physical therapy is. You just see things over and over and over again.
100%. Yeah. I mean, yeah, the first, with any residency, the first, year is super stressful. Like, you're trying to figure out, what way's up? And then you're starting to, just with all the different patients you see these patterns, things start clicking for you,
Right.
and start to become second nature. And that's what, getting out of residency, going in to be kind of on my own, as attending is, I'm comfortable with doing all that stuff. Nothing surprises me anymore,
Right.
so that's
Yeah.
always a good thing. Yeah. That just to have that experience.
Sure, sure. And we talked before we started recording just about our kids and whatnot. And
Yeah.
I had a conversation with my oldest recently, just about doing hard things, right?
Yeah.
And so part of what I was telling him, this was baseball related, but
Right.
in general in life, doing hard things and just what that does, like mentally for us, makes us stronger. And so, I mean, I think the same thing applies for medicine and podiatry and physical therapy, where you have these complex cases and after you see him 2, 3, 4, 20 times,
Yeah.
whatever, the more you see him, it's like, okay, this is nothing. And then you start, the easier cases before are even easier. And so the harder cases now are pretty easy because you see him all the time. And so I think that's the benefit of residency, right?
Yeah,
Like, especially in a
absolutely.
place where you like,
Yeah.
seeing some of that trauma and
Yeah, absolutely. And I think, yeah, just, in the healthcare field, resilience is huge, because you could have, some patients, or, there's a lot going on, and you're using
yeah,
all your mental power to get through, that one patient, looking through records and whatnot, and, really diving down, trying to give them the best care. And then you have to turn around, 5 minutes later, and you got a brand new patient. You have to figure out everything that's going on with them, and you want to give that exact same care to them as well. So that
sure.
can be strenuous on you. But,
Right.
if you've built up those reps, built up the confidence to help you, stay resilient in those motions, in those moments, it can, allow you to continue to give good care
Sure.
for each
Sure.
patient.
Yeah. And it's hard too, and I'm sure you see this all the time where like people don't come to you when they're having their best day. They
Oh
come to you
yeah,
when
for
they're
sure.
having their worst. And so trying to remember that they're in pain or, something's not going well in their life.
Yeah,
And so they're seeking out your care. And so
absolutely. Yeah, we see that all the time. It's just being kind with them, trying to get down to the source of the issue.
yeah, yeah, absolutely. What would you say is one mistake you made early in your career that made you a better doctor?
That's a good question. I think that kind of dials down to being a little bit timid at first. I think,
Sure.
there's been scenarios where I could have been, more, not necessarily aggressive, but more willing to move forward with a surgical intervention,
Sure.
um, to get that where I know the patient would feel better doing that surgery or doing that type of treatment.
Right.
I think, sometimes we try to, placate or, make the patient feel more comfortable. And that also can affect early decision making when you're starting to get in practice on your own. So I think definitely, over the last 6 months, that's changed for me, being less of a people pleaser to the patient, and being more, just worried about getting them better, getting the care that they need.
Sure. Sure. Yeah. I just had a conversation today with a guy. I don't know, like early on in my career, I might have tried to rehab this guy a little bit more, but we're sitting there looking at his x-ray. It's like, you got severe osteoarthritis in your shoulder. Like I can stretch it all day long, but we're only going to maintain so much range of motion.
Exactly.
Strengthening hurts.
Right.
Why don't we have a conversation with the surgeon?
Right.
And so
Exactly.
let's get you over there. Like, yes, this is your second visit here, or
Right.
third. I don't, he hasn't been here very often, but you know what I mean? Like, it's
Yeah,
like,
it's hard because, you wanna exhaust all the conservative treatment, but sometimes when you see the X-ray, you see the symptoms, like, "Hey,
yeah,
this is we can try this, but it's probably not gonna be, get you back to where you wanna be as fast, or it may not get you there." So,
sure, sure. Yep. No, I can totally relate to that too. Thinking back to my time in the Navy, people would come in demanding MRIs because
of
it's
course,
free,
yeah,
right? Like they
right,
want it, they need to know what's going
yeah,
on. It's like, do you really like? I
yeah,
mean, yes, you need to know, but like, do you really need the MRI? Like,
right,
I've got all these tests that we can do. I've got years of experience behind me. I can tell you what's going on. Why don't we start rehabbing this if we need an MRI down the line?
100%.
But learning how to have that conversation and be a little bit more assertive and not so timid is
Exactly,
like
yes.
that's an art.
Yeah, 100%. And like, yeah, there's, you don't wanna come off as a big surgery pusher either, because that's,
Right.
a lot of people wanna avoid surgery at all costs. So I think,
Sure.
just determining to myself, like, I know when this needs to go to surgery, with the past experience and whatnot, and I have to deliver that information when it's appropriate to the patient.
Right. Yep. Yep. Absolutely. So if you could go back to your first day of residency, what advice would you give yourself?
Sleep more before.
I met with a kid that's going into PT school.
Yeah.
He should be starting like right now, but that was when I met with him, he's like, I've got 2 weeks in school. I was like, well, you better enjoy it because you're not
Live it
gonna have a
up.
life for the
No,
next 3 years.
I think I got more pale in Florida than I was in Iowa. But no, I think on a real note, be more confident. You work hard to get to that point. You
Sure.
prove yourself during all these rotations. The program wants you. They want you to be there. They want you to succeed.
Right.
And just to remember that, don't get kind of lost up in the hectic nature of everything. Just stay focused on the task at hand.
Sure, sure. So you kind of mentioned earlier already, like your feet are way more important than you think or than most people think. So if your feet aren't working well, what happens to everything above them?
Above them.
Yeah.
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 So everything can fall apart if your feet aren't working out. It's the contact to the ground. It's what keeps you moving. It's what keeps you stable. If you have, I got this from one of my mentors. Like if you have a flat tire, it's hard to do anything, right? So if
Yep.
you have a bad foot, it's going to throw off everything else. So if your foot's going out to the side, it's going to cause your knees to have issues, and then it works all the way upstream. So and that kind of goes into the point. Stuff upstream can also affect stuff downstream. So it's all a connected chain, and if there's one kind of weak link of the chain, that's going to cause issues throughout the entire process.
Yeah. What's one thing almost everyone gets wrong about foot pain?
Hmm. It's a really good question. I'd say a lot of people like to blame everything on their flat feet,
Yeah.
which isn't always the case.
Sure.
I think flat feet, there's definitely conditions that are related to flat feet that can cause a lot of issues, but it's not the end all be all. I think about 15% of the adult population have flat feet. That's not 15% that are symptomatic related to the flat feet. They could blame like a metatarsal fracture on their flat feet, which isn't super common. Usually see that with higher arches and whatnot, but it's just that they're told by, family members, the parents that they have flat feet and that they've seen them walking weird. So everything is blamed on that. And that can kind of skew additional pathology that may be
Yeah.
going on.
Correct me if I'm wrong, but isn't there a high percentage of Olympic runners that have flat feet as
I,
well?
I don't know for sure off the top of my head, but yeah, I think that sounds about right.
Yeah.
I mean, it's hard to, I don't know for sure.
Yeah.
That'd be something good to kind of look up.
That's kind of one of those things
Yeah.
too that we hear that a lot. People are, oh, I've got flat feet.
Yeah.
It's like,
Exactly.
I don't know. I don't.
Exactly. Yeah. It's like, all right, are your flat feet bothering you? Like, or
Right.
what's going on with your feet that's causing
Yeah.
things off?
It's kind of like people coming in, I have bad posture. It's like, well, is it like, so why do people ignore foot pain for months or even years?
Yeah. So there's a lot of different reasons for that. I had one patient today said that I don't like feet, so I didn't want to see a foot doctor. That's one.
Fair,
Another one that I actually hear quite a bit is that my feet are ugly and I don't want anyone to see them.
fair.
Other things is that a lot of people just deal with the pain. They hear that, my foot aches, they think it's just a normal thing of being on their feet all the time, which there is going to be some general wear and tear, being on your feet, especially if you're on like hard cement, walking all the time. But, I think people tend to push off with the feet because it's a little bit, easier to ignore in a sense because it can be a pain that, is with each step. So it's easier to get used to it over time.
Sure. Let's talk about a big topic I'm sure you talk about every day because we hear about a lot too, but shoes.
Yeah. Shoes.
If you had to pick one everyday shoe for the average person, what would it be?
So shoes are it's a hot topic. So, I get asked that all the time, like, what is the best shoe?
Sure.
So there's different brands of shoes. Like, there's some good ones that I like. There's the Brooks and the Hoka that make a good stable shoe. That's the biggest thing from my standpoint is having a good stable construct for your foot to be on, and then within each of those different type of shoe brands, there's different types of shoes. There's some with zero drop, there's some with a kind of a rocker bottom on it. I think when
Yeah.
you get into the details of that, that's more, activity specific. For every day, you basically want a shoe that's going to be supportive for you and that doesn't have a lot of bend. I always pick up a patient's shoe, hold it up, and then if I can turn it like a washcloth and bend it up and down, that's not a stable shoe. That's not going to provide the support that your feet need throughout the day. So I think it's, less about the brand per se, but just the quality make of the shoe. But out of the most popular ones, it's going to be Hoka. Brooks are a good one. New Balance are starting to make some pretty good ones as well. And, those are usually the ones that we recommend.
What's your thought on the whole like wide toe box?
Yeah. So I think wide toe box is great for a certain population. It's usually with the when the forefoot is starting to spread out a bit more. Usually was seen with like your bunion deformities or your Taylor's bunions. Sometimes with the flat foot, as the foot flattens out, the joints of the foot start to become extra mobile, and then we can see the forefoot kind of spread out as well. I think in that population, that pretty much a wide toe box is going to be necessary because it just decreases the amount of cramping and against the prominences that are on like the medial and the lateral side of the foot with the bunions and the Taylor's bunions. I also think, for a diabetic population too, wide toe box with a high toe height is going to be important just to decrease any chance of anything rubbing causing sores and then all the slew of issues that can form from that.
Sure. Let's talk about bunions a little bit more
Yeah.
since we mentioned it here. Is that something we can prevent? Like if I don't have a bunion now and I wear tight wide toe box shoe, am I going to prevent that or
So what I always tell my patients is that if you have a bunion, just blame your parents. All right. Because most of the time, a bunion is going to be genetic. There's not really a way to stop a bunion from forming once you're predisposed to it.
okay?
There's ways to slow down the progression, though. All right. So the biggest way to slow down progression, stable shoes and arch supports. Those are the two big heavy hitters. There's a lot of studies out there where arch supports have been shown to slow down the progression because a lot of a lot of bunions are related to flat feet. It's kind of the same process I was talking about earlier. As the foot flattens out, the bony architecture of the foot changes. So it allows the joints to move in ways that they're not meant to, and that creates instability, especially towards the front part of the foot and where that bunion likes to form from. So if you can correct some of that with like an arch support where your foot is in a more rectus or a neutral position, you're going to have less mobility and that's going to slow down that bunion progression. Other things that people like to try are like bunion spacers, where they put a toe spacer between the first and second toe. That is a temporary fix. It's not going to fix the bunion. It may feel better when you do those things, but it's not necessarily going to get rid of or stop it from getting worse over time. There's some good literature to show that physical therapy can be helpful with slowing the progression of the bunion, whether that's with working to get that posterior tibial tendon stronger, working those intrinsic muscles of the foot just to create more inherent stability of the foot to slow
Sure.
down that progression. The only way to get rid of a bunion, though, once it forms, is usually surgery.
Perfect segue. Let's talk about surgery on the bunions.
Excellent.
So there's different types, right? Let's talk about the different types of surgery. There's been some articles here in the Boyne recently that have brought some of that to light. I know I've got more questions about that since
Yeah.
since that
Yeah. All right.
news story came out. So let's talk about it.
Yeah, let's get into it. So, there is kind of three different ways to tackle a bunion. There's head procedures, there's shaft procedures, and then there's base procedures. So your head procedure is with the metatarsal head, kind of where because the metatarsal head moving to the inside or the medial aspect, that's the bunion portion rather than the big toe drifting to the outside. So with the metatarsal head procedure, it's essentially a cut of the bone of the metatarsal head and sliding it over more lateral and shaving off any prominence that remains on the medial aspect. So those are quicker surgeries, faster recovery, but the recurrence rate is quite a bit higher associated with it. One of the proposed theories for that is that the chora or the rotation or the angle of deformity is further back over at the first tarsometatarsal joint. All right, so just a, pretty much a joint behind the big toe joint itself. So that's where the mid shaft and the base procedures come into play more. With the mid shaft procedure, kind of similar to if you're just doing a head procedure, just moving everything over to the side. It's just a longer arm and there's some more inherent stability with it, a little bit lower chance of recurrence in some articles. And then in the base procedure, there can be base procedures where you cut a wedge out of the bone and just kind of shift everything over and then fixating it without touching the joint. Those can get really good correction. The problem with those, there's a higher non-union rate associated with it. Then you get to the first tarsometatarsal joint fusions, commonly known as a Lapidus procedure. I think, the Lapiplasty has become pretty, well known as well. It's a similar variant to the Lapis procedure where you're going to the joint that has the main deformity at it. And you rotate the bone over, you cut out the cartilage, and you fuse that joint in a straight position. And there's going to be a longer recovery time associated with that. The main reason is that you're getting two bones to heal together. All right. It's not just getting just a bone cut. You're taking out cartilage and then you're beating the cartilage up and then getting them to fuse together. Different recovery patterns. There's been a lot of recent literature that have people walking on a lapidus, a couple days after surgery in a protected boot. Some people just in a post-op shoe. And then, some people will keep them non-weight bearing for about 6 to 8 weeks while they wait for that bone to kind of heal together. So there's just kind of different school of thoughts for different types of surgeons. I like to keep people off of it for about 2 weeks until the incision site is healed up, and then start walking in a boot after that.
Okay. Awesome. And I would assume, kind of like anything, right? The type of surgery is dependent on the patient and what they've got
100%.
going on.
Yeah. Yeah. So yeah, for like head procedures, we usually reserve those for less severe cases of a bunion. But the base procedures or the fusions of that joint, that's more for severe bunions. Yeah, it's all kind of case by case, with the easier recovery of the head procedure. That's going to be, for older populations where the bone quality may not be as good because it's a little bit easier to do. And that also kind of segues into the new MIS stuff that's, becoming a lot more popular as well, where it's a minimally invasive incision. It's a head procedure where you're not opening up the first metatarsal joint. Rather, you're just kind of coming off to the side of the foot using a burr to cut the head, push it over, and put two screws across it. And that's becoming a lot more popular, recently through the literature because, there's less scarring associated with it and people are able to walk on it sooner.
Are there any joint replacements in podiatry?
So first, yes, there's a few. So first MPJ for like hallux limitus,
Yeah.
big toe joint arthritis. There's plastic implants, Swansons, and then there are some companies that make like a total joint as well. The newer total joint ones for the first MPJ, I do tend to like those a little bit more than the kind of the old school, just like a silicone implant that goes in there.
Yeah.
The silicone implants, they can cause a lot of synovitis or just joint damage. So if you have to take it out, it makes a salvage procedure of like an arthrodesis or a fusion of that big toe joint a lot more difficult with a lot more bone loss. Other places that we see it, total ankle replacements that are starting to they've been around for a while. I think that technology has really improved in the last 5 years or so. We're able to put them in patients for a longer period of time without the poly or the fake cartilage component completely breaking down. And we're starting to be able to do them in younger patients too with a little bit higher of a activity level. So those are the
Interesting.
main ones.
Yeah. Yeah. So like the ankle replacement there, you don't have a whole lot of bone to
They can be
to put that
tricky.
implant in. Is that, yeah, I was gonna say, is that hard to get some stability in that joint, or is it?
So once you get so there's a lot of talus resection. So you take a good portion of that out and take a good portion of the tibia out as well. Once you get the stems in, you've got some room to work with. It's just, the stems can take a little bit of time to get in. You have to make sure you get enough resection. That's where a lot of this patient specific instrumentation has come into play, where you're getting CT scans that are making 3D printed cut guides that make the total ankle procedure a lot more reproducible, so that you can put the cut guide on, it matches, the anatomy of the body, and it makes those, hopefully perfect cuts. And you're able to slide in those stems pretty easily. And then you get a lot of your stability from the poly itself. So you want to put in a poly or just that cartilage piece that's thick enough that you still have easy range of motion, dorsiflexion, plantar flexion, but not a ton of inversion eversion.
Mm.
But you don't want to put too much where it locks up the joint too, because then you're essentially, creating a fusion there
Fusing it. Yeah.
without the other steps.
Right.
But yeah, I mean, once you get the poly in and it fits properly, it's not too bad.
You do
Yeah.
pretty well with
Yeah.
those. Yeah. Another big one, plantar fasciitis, something we see a lot, and I'm sure you do
Yes.
as well. So
Absolutely.
I know that's pretty frustrating for patients. So what would you say is the biggest misconception about plantar fasciitis?
Misconception. I think the biggest misconception is that they think that the bone spur itself is causing the pain. The bone spur that's related to plantar fasciitis for, the the bone spur is on the bottom part of the heel. It's in line with the plantar fascia itself. So
Yeah.
the spur itself isn't typically causing the pain. The spur itself is more of a reaction to the prolonged inflammation to the site, the micro tears of the plantar fascia at its origin that causes the body to create a response and it creates extra bone in that area. Not Patients aren't running on the spike itself. The spike is parallel with the weight bearing surface, so it's not causing that additional pressure there. But people will come in and be like, I have this big heel spur. Sometimes they don't even have pain on their plantar foot. It's somewhere else. They're like, but I need to get this taken care of. And it's, just kind of, educating, talking about the actual, process of how fasciitis works and the other risk factors associated with it, kind of gets them, more comfortable with having that big spur there. If we do surgery on plantar fasciitis, different surgeries, different methodologies. But if you're doing a plantar fasciotomy, cutting that plantar fascia band, typically we just leave the spur there, because the spur itself isn't causing the pain. Once you cut that tight plantar fascia, patients seem to do quite a bit better without touching the spur.
Can you talk about the role of the plantar fascia itself and why do we have it? Why is it there?
The plantar fascia, yeah.
Yeah.
So the plantar fascia works to create stability along the medial, or again, for the arch of the foot. So the reason that we see a lot of the plantar fascia pain on the medial or the inside portion is because that plantar fascia tightens whenever we go from mid stance to kind of propulsion. So it's called the windlass mechanism. So when you push up on the big toe, it makes the arch of your foot a little bit tighter, and that's mostly coming from the plantar fascia itself. Plantar fascia comes from the heel, goes all the way up to our toes, and when our big toe goes up, it causes that plantar fascia to essentially tighten on the bottom part of our foot. And each time that it happens, it creates a little, tension at the origin point, and that's where we can get inflammation on the inside part of our bottom of our foot.
Sure. One thing I think is kind of funny too, when we get these patients in here and you're explaining these things to them, and some of the exercises seem kind of silly until they do them, and they're like, "That's
Right.
really hard."
Yeah, for sure.
But just explain to people like, "Hey, there's 4 different layers of muscle."
Yeah,
And you start showing them pictures online, or bring out a book or whatever, and it's like there's a lot going on in this like little
I
area
know.
here.
It's jam packed in there. Yeah,
Right.
I got it.
Not yeah, let alone like nerves, arteries,
Yeah,
veins, all these tendons wrapping around through there.
it's impressive that we can shove that all in there, right?
It really is. Yeah, there's a lot that's going on there. If you had plantar fasciitis tomorrow, what would you do first?
Stretch. Always stretch. One of the biggest causes for plantar fasciitis is equinus, or just having a tight calf muscle, tight Achilles. It creates extra strain on our plantar fascia. If you can stretch that out, that's why, I tell them stretch breakfast, lunch, dinner, just as much as you can of that posterior chain, just to get that stretched out. That's going to make everything feel a lot better. I think that'd be my number one thing. And then good supportive shoes. That's probably the next
Yeah.
follow up with
Well,
that.
it's like you talked about at the beginning too, like it's not just the plantar fascia, right? It's
Right.
up the chain. And
100%.
so it's what I do tell people too, like, hey, we're gonna stretch your hamstrings, we're gonna
Yes.
stretch your gastroc, your soleus, like all this is attached. Like, yes, your pain's down here, but all this is connected.
Right.
Your Achilles attaches into the heel, attaches into the plantar fascia. And it's like once you show them that and explain it, it's like
Yeah.
you've got to look at other things.
And I think a really good point to confirm all that is that there's been a lot of good recent literature where from a surgical standpoint to treat plantar fasciitis, instead of going and doing a plantar fasciotomy or plantar fasciectomy, it's doing a gastroc recession. So it's like we've seen isolated gastroc recessions that have gotten rid of plantar fasciitis completely. So it's not even touching the heel. It's working upstream where where the thoughtful cause of the condition is. So if, we can reinforce that, in our treatment, to really work on that area, it can cause a lot of downstream positive effects.
Sure. What about the posterior tibialis as well?
For which part?
I mean, it inserts kind of like right next to that plantar fascia. And
Yeah. So posterior tib, it does a lot. I mean, it's the main inverter of our foot, and once you lose that, we're in trouble. And
yeah,
that's where kind of flat feet comes into play. Previously Flat feet was called posterior tibial tendon dysfunction. That kind of got reclassified within the last 5 years or so. Now it's progressive collapsing foot deformity, where, it kind of states, beforehand it was like, all right, it's the posterior tib that's failing. That's what's causing the flat foot to occur. When it's more likely that there's an inherent structure issue to the foot itself. And as that foot structure fails, that causes the posterior tibial tendon to take on extra load that it just can't handle. And once that posterior tib fails, then we don't have that main inverter of our foot anymore. So the nice thing about the outside part of the foot is we got two peroneal tendons that can, kind of straighten things out. FDL, FHL, they kind of work to bring you over, but they don't have that same excursion and that same strength as the posterior tib does. So I think a really good thing that's kind of underutilized for flat feet and conditions related to it is strengthening that posterior tib muscle as much as possible. So eccentric strengthening has been shown it can improve arch height, not as significantly, but the biggest thing is that it can decrease the amount of pain that the patient is having related to their flat foot.
Gotcha. So we've talked about flat feet now. What about the opposite, where people have a high arch,
All
and
right.
where's that a problem, and what can happen because of that?
Yeah. So high arch, call that pes cavus. So high arch feet are pretty much not the exact opposite. There's a lot of conditions that can overlap between them. Plantar fasciitis is seen predominantly in both aspects. When we're on the extreme of a flat foot or of a high arch, but a high arch is what it sounds like. You just got a higher medial arch. When you have a higher medial arch and a cavus foot structure, it causes the bones of the foot to be more locked. All right. So that architecture becomes more crowded together. You don't have as much give to it. So everything becomes a lot more static and you don't absorb as much force as when you're walking on it. So that's why it's nice when we are in kind of that supinated position when we push off, it creates that nice lever arm for us to give us that stability. When we're kind of in that permanent high arch position, it puts a lot of stress and strain on the outside part of our foot and our ankle. So main things that we see with high arch is peroneal tendinitis, lateral ankle instability, severe ones that are, more directed to the forefoot or the front part of the foot. We see a lot of recurrent metatarsal fractures associated with it as well. Cavus feet are a little bit different of a beast to deal with than I would say flat feet. Flat feet, everything's a lot more mobile. You can control them a little bit easier. You can put them into an orthotic that's going to give them in a straighter position because the foot is more mobile if they don't have arthritis going on. With a cavus foot structure, it's already pretty stable. It's just stable in proper position. So it's harder to get that into a more rectus position. And I do think, physical therapy, orthotics can still help with that. It's just a different case.
Where do orthotics play a role in that pes cavus?
Yep. So it's mostly creating kind of a lateral wedge in a deep heel cup. So you're limiting the amount of motion going on within the subtalar joint. And a lot of the cavus foot structure orthotics, they're going to be a little bit more accommodative than, let's say, the flat one where it's going to be more of a structural orthotic. So with the cavus one, we want to try to get a little bit of correction, but we know we're not going to get a ton out of it. So if we can create some additional padding in areas that become hot spots, whether that's in the front part of the foot or kind of the outside part of the ankle. If we can offload those areas a little bit easier with those more accommodative orthotics, we can get some benefit out of that.
Okay. I want to talk about a couple other things
Yeah.
here. So things we commonly see: ankle sprains, Achilles tendonitis, uh, Achilles tendon ruptures, things like that. I'll let you pick which one you want to talk about next.
Yeah. So let's see here. Lateral ankle sprains, good one to kind of dive into because we just talked about pes cavus, high arches, we got your high ankle sprain, your low ankle sprain. High ankle sprain, that's going to be between your tibia and your fibula. You don't sprain that one as often. That's usually got to be a little bit more of a high energy injury associated with it.
Sure.
Low ankle sprain, on the other hand, we sprain that one a lot. So with a low ankle sprain, kind of broken down into three ligaments for that. You got your anterior talofibular ligament, your posterior talofibular ligament, and your calcaneofibular ligament. All of it's kind of based on the weakest link associated with it, which
Yeah.
is our ATFL. So our ATFL, it's it gives out quite a bit. It's one of the weakest ligaments that we have in the foot and the ankle, and it's a really important one too. And so when that gives out, when we twist our ankle really bad in an inversion status, that ligament can just give out on us and it gets attenuated, you get some split tears in it, and it's difficult for that ligament to kind of recover from that. I think the biggest standpoint from a ankle sprain perspective is early range of motion for me. I want to get people moving as soon as we can. First 2, 3 days after the injury, maybe take it a little bit easy because of the height of the inflammation and whatnot. But then after that, it's if you can't walk on it, you're sitting here, you're doing circles with your ankle, you're doing up and down, spelling the alphabet just to get those muscles in that foot starting to move again. Because I feel like if we lock it up too much, then that's where we get stiffness. That's where we get additional inflammation to the area.
Right. Yeah. And I think that's definitely changed even from when I started practicing. Is like, it used to be like, oh, we got to rest it.
Yeah.
We've got to ice this ankle as much as we can.
Mhm.
Don't get up and put weight on it. And so now it's really shifted to where, like, yeah, maybe for the first couple of days we're taking it easy. We're not
Yeah.
doing as much, but we're getting people up and moving and putting weight through it as much as we can early on. And I think it's super beneficial, especially in the long run, to
Oh,
get those
yeah.
people
Absolutely.
moving.
Yeah, and that's the thing with these low ankle sprains. Once you get one, it's pretty easy to get another. So you
Yeah.
have to build that strength back up, or you're going to get put back into the same situation that you were beforehand.
Yeah, yeah. And kind of like we've already touched on too, like it's the base of everything,
Right.
and so you're up, you have that ankle sprain, but then you're up and walking around, and you're at work or school, or everything's pulling down in your legs.
Exactly.
It's sometimes hard to get that swelling to go away because you're just on your
Sure.
feet all day. And
Yeah, and another kind of big thing with the swelling itself is that 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 ligament is it's intracapsular, so it's within the capsule or the connective tissue that surrounds the ankle joint itself. So when there's attenuation and there's little tears in that ligament, it allows continued kind of leakage of that ankle fluid through the tendon, and that creates additional swelling in that area. So
yeah,
it's you're getting hit from, just regular inflammation swelling, you're fighting against gravity, and then you got that fluid coming out from the ankle joint. So
yeah,
that can cause a lot of persistent swelling and discomfort to the area.
yeah, yeah. Let's talk about the Achilles now, because
Yeah,
that's a big topic.
it is.
And something we see a lot here. I mean, we see people post op after they've had a tear in their Achilles, but oftentimes, we see them before the tear when they've got a tendonitis or
Mhm.
tendinopathy. I guess you can dive into that.
Yeah.
So
Yeah, so Achilles can be tough. I think the best way to deal with an Achilles is kind of the same way with plantar fasciitis is just stretching so we don't get ourselves into the position where the Achilles tendon is at a point of failure. I think a lot of these Achilles injuries occur because we have equinus going on. We're tightening those calf muscles. So if we can stay ahead of that, that makes things a lot easier. Once once issues start, then it gets difficult because there's going to be different types of Achilles tendonitis that go on. You got your insertional Achilles tendonitis, where the Achilles meets the heel bone, the calcaneus. You can start getting spurs that form within that Achilles tendon. Once those spurs form, you can't really get rid of them unless you're doing surgery. And that surgery, there's different ways to do it, but you're usually off your feet for a while if it
yeah,
involves detaching and reattaching that tendon back. So if you can
sure,
avoid that at all costs, that's huge. So yeah, and then with mid substance, I think that's a lot more, lot more easily to treat from a conservative standpoint because you have a tendon there that it has the capacity to heal if it hasn't been put through the ringer. If you're doing this stuff with you're doing stretches, you're exercising, you're trying to get that mobility back. Once that damage gets to a certain point, though, then we're at the risk of a rupture, and then ruptures is a whole other pathway we got that you have to worry about is just getting that function back. Because if you lose that Achilles tendon, you lose a lot of function of your foot and your ankle and a lot of
sure,
stability.
sure, yeah. And I don't know how you feel about dry needling, but that's something
Mhm.
I'll do.
For sure.
Especially with the Achilles, we'll go up into the
Yeah.
gastroc, and I kind of like you've said, and we've already talked about, but all that's connected. And so if we can get these gastroc muscles to loosen up, attack the medial head, the
Yeah.
lateral head, get those loosened up. And I like to go like straight into the tendon itself and
Perfect.
kind of kickstart that healing
Yeah,
response
and
and
yeah,
get
and
some blood flow there.
absolutely, and I think, yeah, that's huge, especially with these, these chronic injuries, just making it an acute phase, where we can get some more, healing factors into the area and get things, out of this stagnant position it was beforehand. Yeah, I'm
Yeah.
a huge proponent for dry needling, shockwave therapy, all those modalities to help a tendon that, it still has a chance to do better. It just needs the right treatment for it.
Right, right. Yep. Yeah, we always say like dry needling or any modality really has, it creates this window of opportunity where you feel better. And while you feel better, then we can come out here to the
Exactly right. Yeah,
gym,
it's
load that
perfect.
tissue,
Yeah,
make you stronger, make you more resilient. And so I mean, we're big fans of like eccentric exercises
yeah,
here,
love
especially
it.
for the
Yeah,
tendonitis and
it's huge for the Achilles.
yeah,
I mean, that's been shown time and time again in literature that, eccentric loading is the way to just rebuild, the tendon fibers and whatnot to decrease the amount of inflammation in the
yeah.
area. So yeah, huge. Love that
What about
stuff.
these runners that get stuck in the cycle of, it could be plantar fascia or
Yeah.
Achilles, where it's like it hurts, so they back off a little bit, and
Yeah.
then it feels better, and they hop back into, "Ah, now it hurts." So you kinda get in the cycle.
It's run Runners are tough from that
They
standpoint,
don't wanna stop.
no, they don't. It's that yeah, and you wanna get them to, moving, you want them to do the things that they wanna do. It's just at some point, the body just can't keep up with all those miles, and you do need to take time off to allow that recovery to occur. But I think, yeah, that is a tough one to, try to explain to people because you want them to be happy and running and everything, but you just gotta sometimes put a boot on them and put them in timeout for a little bit.
Yeah. Yeah, absolutely. Boots get hard too. I mean,
Yeah,
from that standpoint, especially post-op when people get stuck in those boots for so long, and then they get out and they're like, "Well, why's my ankle so stiff?" It's like, "Well,
yep,
we haven't moved it for weeks,"
100%.
like, it's gonna take a little bit of work to get that back.
Yeah,
And so
absolutely. So, yeah, with boots, agree, love-hate relationship. I think boots can do great for protecting surgical sites, for protecting against acute inflammation, but I try to keep people out of the boots as much as possible. So when they are wearing a boot, it's whenever you're not walking around. If you're just hanging around at home, you take that boot off, and then it's right back to those range of motion exercises just to keep some motion going on. Because I don't want things to stiffen up because it's hard to get that motion back. So I think the only times I'm a little stricter about the boot is like a big reconstructive surgery where I'm more worried about bones healing together rather than getting that function
sure.
right
Yeah,
away.
that makes sense.
Yeah.
Yeah, yeah, yep. Well, let's go into a little different direction
Yeah.
here. What's one patient you'll never forget?
Ooh, that's a good
A
question.
patient asked
I never forget any of my patients.
one. Maybe I'll give you a little bit of time here. One of mine, I had a patient ask me this, and I had two of one was this is they were both when I was in the Navy. One was a cyclist. He got hit by a city bus. He had a ton of issues. Long story short, he did not want to work. I was brand new therapist, brand new lieutenant in the Navy.
Yeah.
He wanted nothing to do with me. Like this guy came in a wheelchair, just like busted up. And fast forward a couple years later, I get this, handwritten thank you from him saying how great we did. So I'll never forget him, and that's making that story really short. But the one that's more podiatry related is I had this patient who he was a retired Navy diver, and he owned some properties, and he was at one of his properties, and he was walking through the parking lot and just picking up trash, and he was walking in between cars, and there happened to be a pickup backed into a spot, and there was a car
Thank
over
you.
here. Yeah, you can see where this is going, right? So this little old lady gets in her car. She's going to back out. So she thinks. Well, she puts it in drive instead of reverse, and she pins him, not just against the truck, but that truck had a hitch on the back of it.
Yeah.
And so it gets him, right
Uh,
below the knee
yeah.
and degloves
Okay.
that
Yeah.
limb. So no, we were on the West Sound, so over by Bremerton, Washington,
Yeah.
straight across from Seattle. And so he was life flighted to Harborview,
Yeah.
the trauma center there at the University of Washington, and they put him back together. So I
Yeah.
can't remember exactly how many. They cut like 2 inches of gastroc
Oh yeah. You
muscle. It
have
was just
to.
all chewed up. There was
That's
nothing left. And
that's
they
it's a lot of work.
put them all together, and they said, "Yeah, you probably never walk normal again. And one of the reasons I'll never forget this, like just kind of a graphic injury,
Right.
and you don't see that every day.
No.
Um, but this guy was so determined to prove his doctor wrong
Good.
that
I'm a lot.
he was the most like detail oriented patient I've ever had,
Yeah.
like ever. And I think it was the Navy diver in him. So he would come into every appointment. He had this binder, and he had every exercise that I gave him, and he had it all like graphed out. He would have the day, the time, the
He was
exercise.
on it. Yeah.
This is what I felt when I did this exercise. This is how many reps I did. This is what I felt. And he just, I mean, he would sit there and go just line by line, kind of like painstakingly. It was
Yeah, I
like,
know.
oh my
Yeah.
God. So you kind of got to the point where it was like, all right, we got to book 2 appointments for this
Yep.
guy because
Exactly.
like he's just going to go through it all. And then I kind of learned like, hey, let's go through what we can. I'm going to
Yeah.
take a copy of this
That's a
and
good
I'll
way
review it
to
for your next appointment.
exactly. That's right. Yeah.
But he was so detail oriented about everything. And he's a Navy diver. He loved to swim. And so a
Mhm.
lot of his rehab was done in the pool. And I'll never forget, like, the funny thing too, we got, like, towards the end of his rehab, and he was, like he was back to running, he was back to, like, doing everything that they said he couldn't do,
Yeah.
and he's like his biggest complaint, he was like, "It just feels tight." And I was like, "Well, yeah, like, they took 2 inches off of your muscle and pulled it together, like, you're lucky to have a leg." And he was just like, "I just don't understand why it's so tight." And I was like, "Come on, dude." Like
That's pretty funny.
so,
Yeah.
yeah.
I think probably one that really sticks with me, probably back in residency as a third year, we had a patient that we were working up severe flat foot to the point where arthritic changes, it didn't budge at all, no matter how hard you were pulling on it. He didn't remember what his normal foot looked like. He's always been flat footed. So we did the surgery, big reconstructive surgery, fusing talar joint, talar navicular joint, gastroc. I think we did some extra osseous work back by the heel bone too. And, you know, I saw him. I mean, it looked good after surgery, and then I saw him in clinic, just following up,
Yeah.
and he was just so appreciative. He's like, I've never seen my foot like, I've never seen this, like, side of my foot, like, the outside portion of his
Yeah.
foot because it's always been way
Yeah.
out there, and he was just, you know it just kinda, stuck with me from that standpoint because it actually, like, changed his, perspective of himself, like, because 'cause he'd been flat-footed for so long, and
Yeah.
and he wasn't having that same pain that he was beforehand, so
Yeah.
I think that, that one stuck with me quite a bit. There's probably some other ones that are a
I
little
mean,
bit
you
more.
literally changed that guy's life, right? Like
Yeah, I
that's
mean, yeah, it's a good
like
feeling when it all comes together and,
right. I think that's why that's why we get into the healthcare,
100%.
into
Yep.
medicine because like we want to help people.
Yeah.
So
Yeah.
yeah, yeah, I agree. I have one that it ended up being nothing, but I remember I used to do sick call with the Marines on
Yeah.
Naval Base Bangor. It's where all the submarines were. They did the
Yeah.
security for the submarines, and they had some like big armored vehicles, and one was called a Bearcat. And I get this call like, "Hey, this guy's foot got ran over by a Bearcat,"
Oh,
and I was
boy.
like, kind of excited, like, "Oh, I can't
Yeah,
wait to
let's
see
see
what
it.
this looks like. This is going to be a nightmare." And ended up like he didn't actually get run over.
Of course.
It was like I was so confused when he came in. I was like, "You like him walking in just fine." I'm like, what are you talking about? I thought you got run over." He's like, "Oh no, I just like kind of rolled my ankle." I'm
Yeah,
like,
no,
what?
I've had similar ones where, like, lawnmower injuries are really,
Oh
really
yeah,
big for us, and we had this guy, lawnmower ran right over his foot. Didn't take his boot off because he was scared to see it. We get to the emergency room, we take the boot off, not a scratch. Like,
yeah.
he
Like,
thought
hey,
he was
this looks
just
good.
done for. I mean, like, and we did too, we hear lawnmower injury, like, I've seen some mangled feet from that,
Yeah,
so that's
I bet.
yeah, luckily everything turned out fine for him.
Oh man, have you had a complication that's changed how you practice?
I think one that's it's pretty niche, I would say, but Charcot-arthropathy, you know, Charcot disease related to diabetes, where bones essentially turn to mush, and then they kind of fuse back together, and it's fused like in a non-favorable position. It's not braceable, and it's causing sores to fill up. Doing big reconstructive surgeries for those, they're tough. And the complication that's commonly seen is just wound healing in itself. So, I think a lot of those surgeries are, valiant. You're trying to get your patient back to, where they were beforehand, but just seeing those complications afterwards, kind of, you know, I don't prefer to do those surgeries for that reason where it's just,
Yeah.
they're not optimized from, a body standpoint. Their nutrition's not good, their diabetes isn't well controlled. They're not set up for success. So I think that in a way has made me more conscious of even patients that, that aren't diabetic, just making sure that they're optimized from a vitamin D standpoint, they're getting enough protein to help with incision healing, just all those things because I I hate complications.
Absolutely. I agree. What's one thing patients don't appreciate until they're injured?
Walking without pain is a big one. Just getting from point A to point B, like it's such a thing that we take for granted. I mean, if you don't have any foot issues, it's just something you don't think about. But as soon as you have something that either causes pain with each step or you are limited from a weight bearing standpoint, you it really throws off everything. Just some of our non-weight bearing patients, like they just can't get around anymore. They feel down too. They just don't have that independency that they once had. So, just making sure that you can keep your feet in a good condition can, keep you moving and just keep you in a better
Right.
space from that
It seems
standpoint.
so simple, like walking
Yeah.
around until
Probably,
you
yeah,
are on crutches or you're on a scooter
exactly.
or even a boot. Like
For sure.
it
Yeah.
changes
Yeah,
everything.
I
So
mean, yeah, you feel locked into it and you can't get a good escape. Like, even
yeah,
if you like just have to get up and go to the bathroom from the middle of the night, put the boot back on.
right.
That's the kind of thing that I think, yeah, some people just don't
Yeah, it's
realize.
the same. I mean, for us with other body parts, for example, someone has shoulder surgery and they're like, I can't put on a jacket now.
Exactly, yeah.
It's like, or a
Yeah.
t-shirt. Like you didn't think about that before, and it's like, oh,
Right.
I can't,
Yeah, just
I can't do
simple
that now.
things. Yeah, and I think that's a
Washing
another
your hair or
right.
deodorant too. That's something people complain about.
And I think that's a big thing, that's becoming a lot more popular for surgical patients is that before surgery is working with physical therapy
Mm,
to get, comfortable, if they are going to be non-weight bearing, get kind of trained on how to be non-weight bearing in a
right.
successful way that's going to, lower the amount of, danger of instability, and lower the chance of, a lot of deconditioning.
Yeah, yeah. We've had some of those referrals where they're kind of confused when they come in.
Right.
They're like, I got to learn how to use crutches, and
Yeah,
like, yeah, and we're gonna do it on stairs. We're gonna have
exactly.
like curbs, like things you didn't even think about. We're gonna teach you, and we're gonna tell you about the surgery, and yep, what's rehab gonna look like afterwards? Because a lot of people don't know,
Yeah,
and so just kind of
exactly.
explaining all that to them and showing them beforehand, I think is super valuable. So
I think I've read studies where it's increased postoperative functional scoring and pain perception. So I think it
yeah,
it makes a huge
yeah, you
difference.
just know what to expect, and you
Yeah,
don't have that stress of the
right.
unknown, right?
Exactly.
So, what's something medicine has taught you about life?
Well, it's not always fair. I mean, I think I've had a lot of patients, who are just good people that have just been given a bad hand,
Yeah,
and it's just something that you have to, work through, have support, not be afraid to reach out to other people about, but, make it so that, that you put yourself in the best position to kind of get through those times. It's not always going to be, easy for you. You could get, one bad thing over and over and
yeah,
over. It's not like you're due for something good to happen. You just have to be prepared to move forward with everything. And
yeah,
it's just that resilience that we kind of talked about beforehand. There's not just because you had one bad day doesn't mean that you're guaranteed to have a good day the next day. Just having that, that mentality that you just, anything that's gonna kind of come towards you, you just have to take it head on.
yeah, yeah. I would agree. I mean, I've got a patient right now that was Achilles tendon rupture
Mhm.
initially, and young, active, healthy, and nothing has gone right.
Yeah.
Like
I
it
mean,
just, and it's no one's fault. It wasn't the surgeon's fault. It
right.
just like there's just been complication after
Yeah.
complication. It's like
Yeah.
it's hard from a therapist standpoint just to see go through that and try and coach them along, but
Right.
yeah, it's tough.
It's probably the worst part of the job is, you do everything, to the T and it
Yeah,
just doesn't work out.
yeah, for sure. Um, what's the best piece of advice another physician ever gave you?
Good one. I think probably just be confident is one of the biggest ones. Know that you've put the work in. You know that you know what you're doing with everything, and then I think a big one is being patient within the office, while you're seeing patients, no pun intended, but like, just sitting there and actually listening.
Yep.
A lot of the time the patient will tell you everything that you need to know, and you don't necessarily have to ask a bunch of, just like your standard questions that everyone has
Yeah.
memorized. Like, you can get the full story, you can get a better picture of what's going on once you just kind of sit there and just take in what they're going through.
Yeah. I literally had a patient this morning, no joke, that sat here and complained, because it's the shoulder guy I was talking about
Yeah,
earlier, of like, hey, we need to go to the next level. Let's get you to a
yeah,
surgeon. Like, do you have a preference? No, we don't really want to go to this place.
yeah.
We had a bad experience, and they literally said like they didn't listen to us. Like, I had questions, they didn't listen. And that was it. Like, that's why they don't want to go back. So
Yeah, and I think
yeah,
it plays a big role in it, just having that kind of that open communication between the two, but, just, not coming in with like a preconceived diagnosis just based on an x-ray that you saw, actually going in there, listening and then see where that takes you. And I think that, it builds confidence with, the patient themselves. And it also, allows you to actually have a better idea of what the main issue is. Cause sometimes people come in with six different things going on, and just dialing down, where that main issue is. If you get that one feeling better, a lot of that fixes the other stuff. A lot of
yeah.
it's compensation pain that's going on, but they don't necessarily know that that's what the
Right,
cause
yeah,
is.
getting to that root cause. We
Yeah.
talk about that a lot here as
Yeah.
well, and explaining to people why that root cause is important, and we're not just slapping a Band-Aid on it, because we can get people out of pain, but is it gonna fix the issue?
Right.
And so
Exactly.
that's the big thing. Yeah. So if every Iowan woke up tomorrow and followed just one piece of advice from a foot and ankle surgeon, what would you want that advice to be?
I gotta pick between stretch and good supportive shoes. I think the probably the easiest one to do is good supportive shoes. I mean, it's amazing how some people come in with very flat shoes, Converse, whatever, they just don't have any support. As soon as they switch into a good supportive shoe, a lot of their pain goes away. I
Yeah,
think that makes such a big difference with things. And it's the quickest fix. That's why I picked that answer. I think overall, stretching and strengthening of the lower extremity is going to be the the thing that's going to keep issues away better than just a good stable shoe. So
sure. Yeah.
yeah,
I was gonna say of those two, I'd pick shoe as well. Just
it's easier.
knowing people, like,
Yeah, just go get some
people are
shoes.
busy.
Yeah,
Yeah.
yeah,
Yeah. Life gets busy. Like, I get it. Like, I'm a physical therapist. I'm not
yeah.
the best at stretching all the time. And
Right.
so
Yeah, it's
I
yeah,
totally get it. Slap a pair of shoes on, you're gonna wear them every day, all day.
yeah.
So like
And people do, yeah, and people, it makes such a big difference to them. But a lot of time they don't know what to get, and sometimes shoes are they
shoes
can
are
be
expensive
expensive,
nowadays.
hundred
Yeah. It
percent.
seems like I feel like I complain about that just as much as
Oh,
patients
for
do. Like,
sure.
it seems over the last 5, 10 years, like they've gone up. It's like 150 minimum now
Yeah,
for shoes.
yeah,
Like,
for
it's
a good stable shoe, that's what it's looking at, and that's where it's been nice seeing like New Balance is coming out with some more supportive rigid shoes, and that's going to be a lower price point as well. So there's I think shoe companies are picking up on that trend. The people want kind of a more, not middle ground, but a more affordable option, because shoes you have to replace every now and then too. Usually like 6 months to a year, they probably start wearing down on you.
yeah.
So that's
Yeah.
gonna be a big expense that just continues over time.
Right. How do you feel about off the shelf orthotics versus custom?
Yeah, I think off the shelf can be super beneficial in the right kind of population. If we're talking about, mild to moderate symptoms going on, I think a over the counter one can get your foot into a more neutral position, and that can help with a lot of, pathologies going on. It's when we get to those more severe conditions, really bad flat foot's out to the side, really bad cavus foot where you have to try to accommodate, match that arch a little bit more. That's where you need to start, look into a custom orthotic. I think there's a recent study comparing, customs versus over the counter. You know, Over the counter, they can provide good relief, but they don't have the same amount of correction in the heel to get that heel into a better position, and getting the heel into a straighter position, and was what is a major driver of overall foot function. So I think they both play a really big role. I think starting with an over the counter is a great idea. And then, if the over the counter, isn't getting to you where you want to be, then that's when you start talking about custom inserts.
Gotcha. What's one thing you wish physical therapists and podiatrists agreed on more often?
I don't know about that. I think I'm very like pro get moving. I want you to, kind of
Sure.
push yourself. I want to see
Yeah.
how things are. I don't think you guys necessarily disagree with, kind of holding off on weight bearing for like a tendon transfer or something along
Right.
those lines or bony fusions.
Right.
I don't really disagree with
Yeah,
too
I was gonna say,
much.
honestly, I don't think there's really much that I would
Yeah.
I
I
was just
think
curious what you would
Yeah,
say,
I
but,
think, I mean,
uh
for the most part, I think there's been a big, paradigm shift for, where, in the past, it was always limits motion after a surgery. You want everything to heal together before you test it. Well, we're starting to see more that like that activation when you're still in the healing process can promote a better healing process overall. So getting that motion faster is just going to be more beneficial. As long as the bones kind of healed together, that's the one of the bigger things. But, as long as you got stability there, I'm all for, kind of pushing the envelope to a reasonable standard. Yeah.
Right, right. Yeah, and then, like, to your point, if we've got an unstable bone, like, obviously, we don't wanna put weight through
Right.
that, but I like to tell people about Wolff's Law and how we can
Exactly.
build bone, and I
Exactly.
think people are always kinda fascinated, they're like, "Really?" I'm like, "Yeah," like, the more weight we put that's why, I always explain to them, like, that's why people with osteoporosis need to do weight-bearing
Percent
activities, right? Because this bone is gonna remodel, and so even if we have a fracture, you know, obviously, we want that stable and we want it to heal, but, hey, after 6 weeks, like, let's start putting some weight through there.
for sure.
And sometimes sooner in a boot, right?
Yeah.
Control that motion, but
Yeah.
let's still get some weight bearing through
For
that
sure.
and let it heal.
Yeah, I think
So
we've seen recently that a lot of it is turning from less worried about, the structural repair and it's more about the incision healing before, doing walking in the boots.
sure.
Because, incisions that don't heal are not fun for
Right.
anybody. But if you get that to heal, I think a lot of the technology today, a lot of the hardware has come a long ways where things are a lot more stable, kind of on the table or right after the surgery that you can push it a little bit more.
Yeah. 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 And we see that. I mean, with like total joints, total
Yeah.
hips, total knees, like
Yeah.
people are
They
up and
walk all the way
moving.
right
Yeah.
away.
Like right away.
Yeah.
Yeah. And people are always surprised. They're like, I was up that day. I'm like, I
Yeah.
know.
Yeah.
It's pretty cool.
Yeah, I think that's so cool. I hope that the ankle gets to that at one point. I think the ankle is just kind of it's a different beast when it comes to a joint. There's a lot of force that goes through such a small area that, I don't know if immediate weight bearing after a
Right.
total ankle is gonna happen, but we'll see over
Yeah.
time.
There's a lot of force that goes through it, and there's a lot of mobility
Right.
in that. And
Yeah.
so if you have more mobility, you're gonna have a little less stability. And
Yeah. So
so
yeah, exactly.
combine those 2 and it might not
Right.
be great.
Exactly. And that's something, you don't want to be the first to test that.
Yeah, yeah,
So.
right. Yeah, exactly. Sign off on this,
Yep.
right? So awesome. Well, I think that's that's kind of the main questions I had. Is there anything that we didn't talk about that you want people to know?
Let's see here. I think we hit the big ones. Good shoes, stretching, inserts. I think inserts can play a big role, whether that's over the counter or if that's custom inserts. Just something that's going to support your foot structure. When it comes to having flat feet or something along those lines, especially in the pediatric position, I pediatric population, I do see parents bring in young kids all the time and they're talking about how flat their feet are,
Yeah.
but then the kid's not having any pain associated with it. They're not having issues with running, sometimes, sometimes with clearance they'll kind of clip, but not like big concerning issues. And I think a big thing to kind of touch on is, a lot of the time those flat feet in young kids, they straighten out over time. I think about 40% of the pediatric population has flat feet at one point or time. And then, that number drops to about 15% when we're adults. So they're still developing, that bony architecture is still getting, still forming at those ages. You know, I tell parents, just not to, not be super concerned. Don't be pushing for surgery right away just because your feet are flat, because their
Right.
feet are flat. Do some of the conservative stuff, try orthotics, physical therapy, get everything, moving in a good way if they are having some mild symptoms. But if they're not having symptoms, just give it time.
Sure, sure. And I was gonna touch on that too, or just add to that, I guess, like developmentally.
Yeah.
If you look at babies' feet, it's not like they have this big
No,
arch in them, right? They're flat, and as they develop and they weight bear, and those muscles start to develop, the bone structure starts to develop, then that
exactly.
arch is going to start forming.
Right.
With that, how do you feel about just letting kids run with no shoes?
If it doesn't hurt them, I'm fine with it, to be honest. I mean, the architecture is still forming over time. There's when it comes to like flat feet, there isn't really a great one cause for flat feet to occur.
Yeah,
It's not that that they weren't wearing inserts at a young age, or they weren't wearing shoes at a young age. I think there was a study comparing kids with flat feet who were a control group without inserts and a group that were wearing inserts, and they had the same or similar arch heights by the time of maturity. So, I think it's fine to let them, kind of run and play as long as they're not hurting.
so there's a big genetic component to that as
I
well,
think there's
right?
a big genetic component, and I think there's a lot of maturity that still needs to happen with the ligaments and the bones to get into the right position. And, it's just, we don't have there's not a great link between what happens as a kid and as you get older, that like, running without shoes, not wearing supportive shoes. And it's not like the inserts have been shown to fix foot
Sure.
position if
Yeah.
the foot is flat. You're still going to be at risk for having a flat foot, but a lot of times it swings back over anyways.
Yeah. I was gonna say it's probably more important just let them be kids and run around, make sure
Exactly.
they're actually
Yeah.
getting that activity and
100%. Yeah. And then they're using the muscles, they're building the stability,
right.
they're building their own, kind of reinforcements to the area.
Yeah, absolutely. Awesome. Dr. Jager, if people want to learn more about you or they want to find you to schedule an appointment, how can they do so?
Yeah. So you can just search us online. We're Arch Foot and Ankle. My main office is downtown Des Moines, right across from Lutheran Hospital. And yeah, that's probably the best way to do it.
Perfect. Thank you so much for
No
taking time
problem.
out of your busy schedule to be here.
All right. Appreciate it. Thank you.